Good afternoon. My name is John Triedman, and this is from our first EP bootcamp session of PedirhythmX 10. And I'm going to be speaking to you today about deducing tachycardia mechanism from the electrocardiogram. I'm going to start just by reminding all of you how we typically read the electrocardiogram. We look at rate of the electrocardiogram, rhythm, the axes of various waves, the intervals between them in a systematic way. And we relate that to what we know about the electrocardiographic anatomy of the heart, the rhythm generating centers, including the sinoatrial node and the AV node, as well as the working myocardium in the atrium and ventricle, and the specialized conduction system extending from the AV node into the ventricles via the papillary muscles. Essentially, what we would like to do when we look at the electrocardiogram when we're thinking about tachycardia mechanisms is to look for recognizable and recurring patterns. So when we see these known electrocardiographic patterns, what can we learn? Well, first of all, we can often create a mechanistic hypothesis. In other words, a way of thinking about what we see that gives us an insight into what the arrhythmia is. And if we know what the arrhythmia is, oftentimes we can make very specific prognoses and prescribe specific therapies, either acute or chronic, to address those arrhythmias. Just reminding you about some of the things that we typically look at by way of metrics in electrocardiogram. I know these are all familiar to you, but I just want to remind you how we designate the various waves of the electrocardiogram, how we measure various intervals, and in particular, how we look at the heart and its position in the chest in relationship to electrocardiographic leads, AVR, AVL, AVF leads 1, 2, and 3, which are in the frontal plane, and then in the sagittal plane leads V4R through V1 and around to V6, allowing us to look at the heart from different electrical perspectives. Today, I'm going to be describing both supraventricular and ventricular rhythms, but I'm going to be focused on supraventricular rhythms, which are the bulk of what we're asked to address looking at electrocardiograms clinically. We'll be thinking about narrow rhythms, wide rhythms, or as we often say in our service, whether or not the patient is showing their usual QRS morphology, which may be narrow, or it may be the same wide complex rhythm that they have in sinus rhythm as well. We'll talk about atrial rhythms, both automatic and reentrant. The automatic rhythms predominantly including ectopic atrial tachycardias, the reentrants, atrial flutter, and most types of atrial fibrillation. We'll be talking about AV reciprocating tachycardia, see some examples of them, including the typical ones such as WPW and concealed accessory pathways, AVNRT, and the atypical ones such as PJRT and some antidromic tachycardias. AVNRT, both common and atypical forms, and junctional tachycardia. And we're not going to deal with each of these in great detail, but I'm hoping to give you some examples of all of them and useful ones at that. So just refreshing our mind as to mechanisms of different types of SVTs. We have SVTs arising from the atrium in the form of atrial tachycardias. We have atrially driven tachycardia such as atrial fibrillation, a somewhat random reentrant pattern in the predominantly arising from the left atrium, atrial flutters, oftentimes circumnavigating the ostium of the tricuspid valve. But we're going to start by looking at the most common types of arrhythmias that pediatric electrophysiologists are asked to look at, which is to say AV reentrant tachycardias, or tachycardias that are mediated by reentry via an accessory pathway, and also AV nodal reentrant tachycardias. A very useful rubric for looking at these types of tachycardias, both AVNRT and AVRT, and distinguishing them from one another is to think about what we refer to as the VA interval, understanding that tachycardias that have a long VA interval are most likely to be AV reciprocating tachycardias, that is to say, mediated by an accessory pathway. So what do we mean by long VA? Well, here, if we look up close at some of the leads in this 12-lead tachycardia, we can identify P waves coming after the QRS. We see them quite clearly. There's a measurable interval from the R wave to the P wave. And just the fact that we can see that tells us that this is a relatively long interval between the onset of QRS and the onset of P. In this particular patient, about 100 or 110 milliseconds if we measure that using calipers. Compare that with this arrhythmia here, also an SVT, but it's actually quite difficult to see where P's might be. One could argue that perhaps there's a P there, but we really don't see it in any other T wave or anywhere in these. And so we infer that the P waves are actually occurring on top of the QRS here. And we call this a short VA tachycardia. The measurement of what a short VA might be would be about 0 milliseconds from onset of QRS to onset of P. But of course, we can't actually see the P here. And a lot of the time, we just can't exactly tell. So here's another electrocardiogram. I'll give you a tip and tell you off the top that this is actually an electrocardiogram of someone who's in AV-NRT. But if we look closely, one could argue if you take a microscope, and I'll encourage you generally not to do that, but if you take a microscope and begin examining the T waves closely, you might convince yourself that there are some P waves buried in there. So how can we take advantage of different things which might happen to elucidate that? Well, first of all, we have to recognize that there are cases that we will encounter in our regular practice where we simply can't tell the difference. And we know that we have SVT, but it's not possible from the surface electrocardiogram to say with absolute certainty whether or not it's AV-NRT or AVRT. But here's an example of an SVT which fortuitously has a little temporary break where we actually get to see both a beat of tachycardia and a beat of sinus rhythm. And in particular, if we look at the T waves that are inscribed after the first sinus beat after a termination, we can compare them to the T waves of the last tachycardia beat. And in this particular case, we can see that there is, in fact, a P wave buried in the T wave, which tells us that this is actually a long VA tachycardia. There are some other things that we can encounter adventitiously in the electrocardiogram, and we should never, whenever we see something change in an SVT or in any type of tachycardia, we should always ask ourselves, how can we use that little transient event to tell us something? And here we see an electrocardiogram which goes from narrow or usual complex to a left bundle branch complex and then back again. So we have two different states of the tachycardia. The question is this an AV-NRT or an accessory pathway tachycardia? And I'm going to further say, and what can we say about the tachycardia beyond that? Well, what we can do is we can measure the cycle length of the tachycardia in left bundle branch blocks and left bundle branch block, and we learned that it's 250 milliseconds. We can similarly measure a shorter cycle length in the narrow complex tachycardia and show that it's 215 milliseconds. So because the cycle length of the tachycardia changed with the resolution of left bundle branch block into narrow complex tachycardia, we know that AV-NRT does not involve the left bundle. Therefore, this must be an accessory pathway mediated tachycardia. And further, the fact that it was prolonged by a bundle branch block on the left side implies that the accessory pathway is on that same side. In other words, lengthening of conduction down the left side of the heart, if it lengthens the tachycardia, suggests that the accessory pathway is located on the same side as that bundle branch block was observed to occur. Now let's look at another type of SVT. I'm going to call this a long RP tachycardia. In particular, this is the tachycardia that we refer to as PJRT, which also stands for the permanent form of junctional reciprocating tachycardia. And you're going to observe in leads 2, 3, and F, which we think of as our inferior leads, that the P wave is downward going, suggesting that there is a superior P wave axis. It's pointing down in 2, 3, and F, which means that the P wave is depolarizing upwards. And when we actually look at the timing here, we can measure from the Q wave or the R wave to the P and back forward. And what we see is we actually have an RP which is greater than our PR interval. And that's a diagnostic criterion for PJRT. What's interesting about this is that the retrograde conduction up the accessory pathway is so slow that it makes it very hard for this tachycardia to terminate and stay terminated. And in fact, when we look at these patients over a long term and looking at their trend, what we'll see is incessant recurrences of their tachycardia. And just as a point of reference, it's also relevantly useful to take advantage of these information as well. The monitoring telemetry data, the pattern of heart rate through the day can oftentimes give you additional clues into the mechanism of the tachycardia that you're looking at. So let's move on to junctional ectopic tachycardia, a tachycardia that we see plenty in postoperative patients, occasionally in congenital cases, but much more commonly in the perioperative ICU environment. So here, just looking at the intervals between the RR, you'll notice that there are 2 distinct PR intervals between each QRS here. The green intervals are all about 340 milliseconds, and every 4th beat we see a shorter interval at 270 milliseconds. So what's going on here? Well, if we look at the rhythm strip below it, the AVF lead, we can see that we can actually identify Ps that are a little bit out of sync with the QRS. And in fact, although we can't see them everywhere, we can infer that there are additional Ps located on top of the QRS complexes. The reason we're not able to see them, of course, is that the QRS complex is there and it's bigger. So the P wave interval is actually longer than either of those. And what we're seeing here is an asynchrony between the QRS complexes and the P waves, which allow a P wave to penetrate the AV node, capture it, and conduct every 4th beat, resulting in a shorter interval. So there we see essentially VA dissociation, a narrow complex. The narrow complex is not changed in sinus captures, therefore junctional ectopic tachycardia. I want to talk a little bit about Wolff-Parkinson-White syndrome. You'll remember that WPW is antegrade conduction of sinus rhythm over an accessory pathway, resulting in a delta wave. It can also result in both orthodromic tachycardia, where activation runs from the AV node down through the specialized conduction system and back through the accessory pathway, and occasionally antidromic conduction. Now, in this particular picture right here, the accessory pathway is drawn in the right lateral location of the heart on the free wall surface next to the tricuspid valve. But we already know from looking at our left bundle branch block example above that we can also have accessory pathway on the left side of the heart. And in fact, we can have accessory pathways basically anywhere along the AV groove on the right or left sides of the heart. So over the years, there have been many attempts by basically most fellows in pediatric EP and adult EP to come up with various simple rubrics by which you can look at the electrocardiogram and predict with some degree of precision where the accessory pathway is located. They all work a little bit. None of them work perfectly. That's why there are so many of them. Perhaps the most famous of them is down in the lower right here, the so-called Aruda criteria, which were the first major effort that was made to do this. I'm going to give you a slightly simpler rubric. And then at the end of the day, you're going to have to go into the cath lab and find out where the pathways actually are. First of all, here's a patient with the right anterolateral pathway. The pathway is located close to the sinus node, relatively far from the relatively closer to the sinus node than is the AV node. And usually there's lots of conduction through these pathways. And so what you see is a very wide QRS because most of the activation of the QRS comes from the pathway, and a left bundle branch block consistent with the right-sided location of the pathway and cell-to-cell conduction in the ventricular myocardium. Note that the delta waves in this particular tracing are all positive in 2,3-F, indicating that the pathway is high on the right side and the vector of depolarization and pre-excitation is pointed downward. In contrast, when we have a posteriorly located pathway, here's a right posteriorly located pathway, we have a superior delta axis in 2, 3, and F. And then as we move on to the septum, we notice that the pathway begins to show delta wave polarity, which is mixed or indeterminate in the inferior leads. So when you begin to see less pre-excited electrocardiograms with indeterminate axis with respect to superior or inferior in the inferior leads, begin to think that you may be dealing with a septal pathway, in this case, a left posteroseptal pathway by chance. And finally, a pathway we generally love to see, which is left lateral pathways. We love to see them because they're typically pretty easy to ablate. These electrocardiograms can be virtually normal. They have a discernible PR segment, and sometimes they have extremely subtle pre-excitation. Just the hint of pre-excitation with loss of the septal Q wave in V6 and lead 1. Just to complicate things even a little bit further, in asymptomatic Wolff-Parkinson-White patients, somewhere between 5 and 10% of them will not actually have Wolff-Parkinson-White. They'll have what we call a fascicular ventricular fiber, or a fiber that runs from the high body of the AV node and specialized conduction system down to the septal myocardium. This is not a risk factor for the arrhythmic complications of WPW, but can result in patterns of electrocardiography that are easily mistaken for WPW. And frankly, these can sometimes be quite dramatic. And the only way to figure them out, honestly, is to study them, either with electrophysiology study or by administration of adenosine under monitored conditions. I'm going to move now to other atrial arrhythmias, including atrial tachycardia, atrial flutter, atrial fibrillation, give you some basic electrocardiographic tips regarding these topics. Here's a patient with ectopic atrial tachycardia. This can be extremely difficult to distinguish, especially from PJRT. But what's important to understand about ectopic atrial tachycardia is that usually the atrium is going quite a bit faster than the AV node would like to be going, and that results in a long PR interval. So if we look up here, we can see the onset of the P wave, and we can see quite a generous, even prolonged for this rate, PR interval, which helps us identify the P wave as inappropriately fast for the autonomic state of the patient. There are other tricks to identifying the P wave in ectopic atrial tachycardia. Here you see a patient, again, with a funny event happening during the rhythm strip. I'm going to pick out this area and have a closer look at it. And we can see the P waves here. This is actually continuous arrhythmia with P waves that march directly through the tracing. We see a blocked beat with a narrow complex rhythm, and then presumably conditioned by the brief pause in RR interval, a series of aberrated beats, left bundle branch aberration immediately after that. But this is all one run of EAT. This is actually what you might more commonly see in a patient with EAT, which are paroxysms of variably conducted tachycardia, sometimes with aberration, and oftentimes with a relatively irregular degree of conduction. But you should also, excuse me, I forgot I had this slide in here, going back to heart rate trends with patients who are manifesting rhythms of this sort. The variability in their rate from beat to beat can lead to what we conventionally refer to as the chia pet sign, with little blades of grass growing off the humps. You can see the period of time where the arrhythmia was relatively quiescent here in this patient during the sleeping hours. And finally, just one other sort of specific pattern that we'll not infrequently see in patients with EAT, which is a hyper rapid EAT with a relatively high degree of AV block. Here you see EAT with actually the cycle length of probably no more than 160 milliseconds, a rate well over 300, resulting in a pattern of conduction not dissimilar from AFib, which I'll show you an example of in just a minute. But before we get to AFib, let's talk about atrial flutter, sometimes also called IART, specifically when it relates to postoperative arrhythmias in patients with congenital heart disease. But this is actually classic atrial flutter. And what I mean by classic is a pattern that we all should recognize, if only from our medical and nursing textbooks, which is a sawtooth baseline, a sawtooth P wave that you see in leads 2, 3, and AVF. And here you see an atrial flutter with a cycle length of 185 milliseconds and variable conduction, resulting in intermittent, slower and faster heart rates, but generally of a relatively irregularly regular rhythm. This is sometimes quite easy to see. Here's somebody who has giant atria, and you can absolutely see the atrial flutter, probably better, frankly, than the QRSs. But it can also at times be quite subtle. Here we just see a couple of P waves during a pause in conduction. And the way we know this is atrial flutter and not atrial fibrillation is by looking at the intervals between the QRS complexes, 420 milliseconds over and over and over and over again. Here, by contrast, is a patient with atrial fibrillation. You can see the baseline is considerably less organized. And also, our interval is a lot more irregular. And when we're dealing with that same congenital heart patient, perhaps when their atrial flutter degenerates at some later age into AFib, we can distinguish one from the next by looking at the intervals between their RRs. I'm only going to deal very briefly with a couple things that we need to be aware of and that we find useful in looking at the electrocardiogram in VT. Talk a little bit about automatic ventricular tachycardias, which occur in healthy normal hearts, including RV outflow tract tachycardia and LV fascicular tachycardia, also called Bell-Hassen's tachycardia, and very briefly about reentrant and myopathic VTs. In fact, we'll talk about them first. This is the most myopathic ventricular arrhythmia you'll see, and you really don't have to worry about this patient, because when you see a 12-lead electrocardiogram of ventricular fibrillation like this, you know that the patient already has a Berlin heart or some other form of VAD implanted, and that their rhythm doesn't matter much anymore. It matters a lot more when you see a patient like this who's having paroxysms of scary, wide, complex tachycardia. It's important to be able to distinguish those tachycardias from SVTs with aberration. So how do we do that? The first thing we should look for when we see a wide complex tachycardia of any sort is what the relationship between our ventricle and atrial rates are. And if you look at this particular case, you'll see that in addition to the QRSs, we can see P waves at a relatively low rate marching through the QRS without being affected by the timing of the QRS at all. So the ventricle is clearly leading the atrium, and in fact having no effect on the atrium at this in this particular case. So we know that this patient has an arrhythmia which is not being driven by the atrium. Can we see it in something like this? It could be a little bit more difficult at times, but I would contend that if you look at this, even here, although you might get entranced by the ugliness of the QRS, if we look between them, we can make a guess that perhaps there are P waves in between and say, yes, this is also a case of ventricular tachycardia, one that we had better take care of with VA dissociation. How do we know it's ventricular tachycardia and not just a usual complex junctional tachycardia of the type we saw before? Well, you remember when we had sinus capture of jet, as I showed you before, the early beat came at the same with the same morphology as the sustained tachycardia. In this case, we can infer that there's VA dissociation, and here we have a capture beat. And the capture beat is narrow. It has basically the same shape as sinus. The next beat, also partially a capture beat, we'll call that a fusion beat. And then we go back to a ventricular beat with quite a different morphology. So we can say with 100% certainty here that this is not junctional tachycardia with aberration. This is, in fact, ventricular tachycardia. One other little trick that we can use is looking at the onset of the tachycardia rhythms. And in particular, I'm just going to point to this very first beat right here. We have a P wave occurring in the capture beat before it, and we have a very clear P wave occurring here with a non-physiologically short PR interval afterwards, indicating that QRS complex was not triggered by the P wave that you see there. So again, an example of ventricular tachycardia. Finishing up with just a couple of examples now. This is RVOT-VT, and this is something you'll see in many patients. I want to point out to you here that the patient has an inferior QRS axis. In other words, the QRS is positives in leads 2, 3, and F. And it has left bundle branch block pattern. So what does that imply? Well, what it shows us is if the tachycardia, if the QRS axis is pointing downward and to the left, then that means the origin of the tachycardia is at the base of the arrow or upward and to the right, right in the outflow tract of the right ventricle, sometimes the conal septum. Conversely, this is the other form of common tachycardia that we'll see in normal hearts, LV fascicular tachycardia, which I also called Bell-Hassen's before. And you'll notice in contrast here, in 2, 3, and F, the axis is now a superior axis. And instead of having a left bundle branch block, we have a right bundle branch block, a rather narrow one, to be frank. So if we apply the same logic to that, here we have our frontal and sagittal plane axes again. Now we have an axis which is pointing upwards and to the right. And we can infer from that that the origin of the tachycardia is down and to the left. So I'm going to end with that, with this thought, actually. I'd like to thank you for your attention. I hope you realize that there's a lot that we can get out of the electrocardiogram simply by looking at its standard features, looking at various gifts that were given by circumstance, by counting up the A's and V's, and by not losing your head when you're confronted with a puzzling tracing. Thank you very much.